Okay, we'll go ahead and move on to our next talk. I'd like to introduce Dr. Alyea. He is currently an Associate Director of the Stem Cell Transplant Program at Dana-Farber Cancer Institute, Brigham and Women's Hospital in Boston. He is also an Associate Professor in Medicine at Harvard Medical School. He completed his research fellowship in Raine Institute at St. Thomas Hospital in London, England. He completed his clinical fellowship in medicine at Harvard Medical School and fellowship in medical oncology at the Dana-Farber Cancer Institute in Boston. Dr. Alyea's clinical and research interests center on the treatment of hematologic malignancies using allogeneic transplantation and adoptive immunotherapy. He is the PI for a national cooperative group trial of allogeneic transplant for patients with CLL. Dr. Alyea is also the PI on several other investigator-initiated and cooperative group trials. He has also collaborated in over 40 selected peer-reviewed publications, and he will be speaking today on the diagnosis and treatment of acute leukemia. Please join me in welcoming Dr. Alyea.
So again, thank you very much for the kind invitation to speak to this group. I appreciate the invitation. I was not given an easy task to follow Dr. Perales' excellent talk about complications of transplantation, and then also to follow about an hour after lunch when I know when in this room you're trying to slowly dial down a little bit. So as we talk about this topic, what I'd like to do is we'll pose a couple clinical scenarios so that you can think about your approach to a patient with AML and the approach at your institution. And in many cases, there won't be one right answer, but it'd be interesting at the end for us to get a spectrum of the opinions that are out there. I do not have any disclosures. So first of all, AML is one of the principal indications for transplantation in this country and has grown significantly, supplanting CML from over a decade ago. And what I'd like to talk about in the next few moments are several important issues in patients with acute myelogenous leukemia. First is the very common issue that we run into in the clinic for referrals are patients who are referred for considerations of transplantation when they are in first complete remission. This has been an area of debate for the past 10 or 15 years or so, and now we're beginning to get more clarification as to where transplant is appropriate. In addition, there's a particular subgroup that remains a challenge, which are those patients whose cytogenetics are normal. And what that does is it brings up really the whole next level of approach to patients with AML, which is the genotypic abnormalities that are being identified and the risk stratification that's followed. Another very common issue in patients with acute myelogenous leukemia is how one approaches the older patient with acute myelogenous leukemia. As we know, AML is a disease of older individuals. What is old? Old is 10 years older than the speaker in most cases. But usually people consider that about 60 and beyond. But this is a great challenge, and as we know, the advent of reduced intensity conditioning regimens has really opened up transplantation for the benefit of many of these patients. We'll also talk a bit about conditioning regimens. There's certainly been a lot of talk at the meeting about conditioning regimens. What's the appropriate regimen? Is it an ablative regimen, or is it a non-ablative regimen, or a reduced intensity regimen for the patients? And importantly, what is the role of T-cell depletion, either through mechanical T-cell depletion or the use of serotherapy, which groups have used to try and reduce the complications of transplantation, particularly graft versus host disease. But what's the counter to that, which is increased risk of infections? And really the biggest problem that we face in all areas of transplantation is risk of relapse. Also like to talk about donor selection. As Dr. Perales just showed, the results from match-related donor and unrelated donor transplantation are now approaching one another. Perhaps is there an advantage to using an unrelated donor over a match-related donor should you identify a related sibling? And then finally, as we talked about, one of the great challenges in transplantation is, unfortunately, the development of relapse after transplantation. And what I'd like to do is just review a couple methods that one can deal with in terms of the risk of relapse. And there have been lots of other very important presentations at this meeting regarding other strategies. So the first case I'd like to present to the group is a 35-year-old, previously healthy man was found to have AML with myelomonocytic differentiation. The karyotype was normal. leukemic cells showed the NPM1 wild type and a FLT3 mutation. The patient achieved a complete remission following 7+3 chemotherapy, and his complete blood count is now normal. He presents to you in the clinic, and the patient comes with his sheet saying, I have a brother who is HLA identical. What should we do? And which of the following approaches would you recommend? You can take out your iPhones and open up the app that allows you to vote on this. There is not one, but everybody has their phones out anyway. But so you can play like it. Number one would be, would you recommend azacitidine monthly until the disease progresses? 2, would you recommend a reduced intensity conditioning followed by an allogeneic transplant using a sibling? A myeloablative conditioning followed by an allogeneic transplant, again using the sibling? How about 1 to 2 cycles of high-dose Ara-C followed by a myeloablative transplant? Or the chemotherapist might choose 3 to 4 cycles of high-dose Ara-C and call it a day and observe. So just before we go to the next slide, what I'd like to do is just go back to the case, and we'll just highlight the information that we have that's going to help us make this decision. First is age. Next is the prior health of the donor, suggesting no antecedent hematologic disorder. We have the diagnosis of AML. In the old days, classification by histologic and phenotypic would be helpful. However, now we've moved on to karyotypic analysis for risk stratification. And more importantly, we've now moved on to a better understanding of genetics and the cytogenetically normal, looking at several genetic profiles as well. So what's the current risk assessment for patients with AML in 2012 and 2013? Well, first of all, as we mentioned, is patient age. As we'll talk about, age plays an important role, not only because of the fitness that it declares of the individual, but also it tells us a lot about the biology of the disease, because the disease in older individuals is fundamentally different from AML in younger individuals. Next is karyotype. We'll discuss the different risk factors there. We talked about the issue of primary versus secondary disease. Secondary means a primary hematologic disorder or therapy-related AML. Those patients are all, no matter what other profile issues they have, are all considered at high risk and considered candidates for transplantation. And then importantly, we'll look at some of the molecular studies that are now available that are being used in your institution to help decide who should move on to transplant. The FLT3 mutation, which has been identified as very unfavorable. NPM1 mutation, which has been identified as favorable. The CEBPA biallelic mutation has been identified as favorable. And KIT mutations, which can appear even in patients who have some cytogenetically favorable disease, has also been unfavorable. And now what we're learning more from Ross Levine at Memorial and formerly at our institution, as they've published on larger groups of genetic profiles, we're going to understand the future importance of the IDH1 and 2 mutations, DMTA, and the TET mutations as well. So the Europeans have actually done a very nice job with the European Leukemia Net guidelines, and they've divided groups of patients into favorable and adverse, and they list here the survival for each of these groups and their profiles. So if we look first up on the slide in the favorable group, we can see that they have a predicted survival of 65%. And as many in the group know, favorable cytogenetics that have been previously identified have been the 821 with the Runx abnormality, inversion 16 also being a part of that picture as well. In the intermediate group, and now added to the favorable group, are the mutated CEBPA group in a person with normal cytogenetics. And what may apply to our patient would be somebody with a mutated NPM1 and a FLT3 ITD in the normal karyotype may identify somebody with a favorable prognosis. An intermediate prognosis where the survival drops down to 50%, we can see wild-type NPM1 and the FLT3 ITD, or the wild-type NPM1 without the FLT3 ITD. Down into the intermediate group, we have any cytogenetics not classified as favorable or otherwise. That's kind of the wastebasket category for people who don't otherwise fit. And as we know, when we get down to the adverse categories, we see patients with monosomy 5, monosomy 7 with monosomy karyotypes portending a very poor prognosis, not only overall with chemotherapy, but also with outcome with transplantation as well. So what is the outcome in cytogenetically normal AML patients? Well, what's the prevalence of these abnormalities? 53% of patients had an NPM1 mutation, which, as we talked about, is favorable. 31% had the FLT3 internal ITD, unfavorable. 11% have the FLT3 tyrosine kinase domain mutations, favorable 13% with the CEBPA mutations, the MLL, and other mutations listed. So if we look at the outcome to try and help us decide what we should do with the patient that we presented, let's look at the relapse and overall survival in patients with AML depending on their NPM1 and their FLT3 ITD mutation status. And the important aspect here is in the overall survival, where we see that those patients who have the NPM1 positive but the FLT3 negative, have actually an overall very good survival. However, those patients with the presence of the FLT3 abnormality do less well and are often considered for transplantation. And that group is highlighted here. So what is the role of allogeneic transplantation in first remission for patients with AML? Well, as you know, there have been several prospective trials over the years assigning patients to allocation of either transplantation or non-transplantation approaches. These have often been done called donor versus no donor analysis, whereas if you have a donor, you're assigned to an allogeneic arm. If you don't have a donor, you go on to get chemotherapy or an autologous transplant. And there have been well over 5 of these studies done both in this country and in Europe, and they show that the outcome for patients undergoing autologous transplant is very similar to chemotherapy alone. Autologous stem cell transplant, allogeneic stem cell transplant was associated with a lower relapse rate versus autologous stem cell transplant or chemotherapy, where the treatment-related mortality was low. We do know that treatment-related mortality is much higher, as Miguel just pointed out, in the allogeneic arm, and that often results in the overall survival curves that we see. There's a balance between toxicity and benefit. And depending on the timing and the intensity of chemotherapy, we know again that allogeneic stem cell transplant is associated with a high treatment-related mortality. John Careth at our group worked and did a meta-analysis where he combined information from all these trials together and found that there was a slight benefit to sibling transplants in all groups except favorable cytogenetics. So from that group where we're using cytogenetics alone, there is an advantage if somebody has an HLA identical sibling to proceeding to an allogeneic transplant in all categories of AML and first complete remission except those patients with favorable cytogenetics. What other recent studies have also given us insight as to the role of transplantation? They include that mud transplants are very similar to the outcome for patients with SIB transplants, and that was information that Miguel just presented in that last slide. And importantly here, the issue of who is your donor. And a young donor, appropriate donor found in the registry, may be better than an older donor found in the registry. So that's another factor when used in choosing donors. The younger donors, young seems better in all categories, and here it works in donors as well. Young donors better than old donors, and that'll be important when we talk about older individuals with AML. So is there a role for allogeneic transplantation in AML with patients with normal cytogenetics? Again, we go back to that same question. There's no benefit for allotransplant in patients with the mutated NPM1 and the wild-type FLT3. However, if we see in other cases, that appears to splay apart when they did a donor and no donor analysis. So what are the guidelines for patients less than 60? At our institution, standard induction chemotherapy consists of daunorubicin. Idarubicin is used at other institutions, and cytarabine in combination given by a continuous infusion for 7 days. Post-remission therapy involves, if patients have poor cytogenetics, those patients are referred for allogeneic transplant. In patients with favorable cytogenetics or normal cytogenetics, or, as we saw, the NPM1 mutation or FLT3 wild type, which defines a good sub-risk group, those patients are assigned to 4 cycles of high-dose Ara-C. And finally, for those patients with intermediate cytogenetics, either of these options are appropriate, but as our institution, given the data that we've discussed, most of those patients are referred for considerations of allogeneic transplantation should they have a suitable donor that's been identified. So the NCCN and the ASBMT recommendations, again, suggest that we stratify patients by risk. They recommend allogeneic transplant for patients younger than 55 with poor risk AML, recommend it for those patients with good risk AML, and again, come down right in the middle for those patients who have the intermediate risk. But again, the body of evidence would suggest that we're moving more toward allogeneic transplantation having a role in this disease. So cytogenetics predict the So importantly, cytogenetics help us define who goes to transplant. Can cytogenetics also tell us how people are going to do after transplantation? Meaning that does an allogeneic transplantation, if you have really bad cytogenetics and you get a transplant, does it wash the slate clean and your outcome is just as good as somebody who has another cytogenetic profile? Well, Philippe Armand at our institution had looked at our own data of well over 1,000 transplants over a decade, and then took that training set to the CIB-MTR group and did a retrospective study to look at the impact of cytogenetic abnormalities and outcome after transplantation. What he did was he looked at adult patients with AML. He excluded patients with APML and prior MDS. He also looked for patients in CR1 or CR2, bone marrow or peripheral blood. He included centers with over 20 eligible patients who were transplanted during this time frame where we have good cytogenetic data for patients. Patients who had unknown or unobtainable cytogenetics were excluded. Patients who had a prior auto for AML were excluded, and patients with the Philadelphia chromosome, which really define a unique subset now addressed in a very different way, were also excluded. And what he performed was a multivariable analysis trying to create a model to look at overall survival. And he compared it with existing schemas that are out there and generated a new schema to try and predict outcome for patients after transplantation based on their cytogenetics. And found that those patients with favorable profiles, including inversion 16, those patients who go to transplant have a very good outcome. Intermediate outcomes were seen in patients with normal, 821, which again in the other classification we consider in the favorable group, and the other abnormalities mentioned here before, mentioned as well. And then those patients with adverse cytogenetics or very complex cytogenetics defined a very poor risk group. And these groups broke out in defined groups with differences between them. We can see here favorable, normal, intermediate, and then this adverse risk group as well. He looked at the cumulative rates after transplantation, these multivariate models in terms of relapse and in non-relapse mortality. And not surprising, those patients who had very adverse scores had a very high risk of relapse, intermediate and favorable being less so. And in the non-relapse mortality group, we can also see that a very similar outcome for actually the groups not reaching a level of statistical significance. So what drives this model is the risk of relapse after transplantation. If we look at the probability of overall survival after transplant by conditioning intensity, interestingly, we see that myeloablative transplantation, we see this breakout favorable, intermediate, and adverse, but we also see almost an identical profile in those patients undergoing a reduced intensity transplant as well. So what does that tell us? Well, that probably tells us the graft versus malignancy effect plays a significant role in curing these patients with AML after transplant. So the conclusions were that there's now a transplant strategy classification for patients going to transplant that can help you define how people will do after transplant. And those include, again, the inversion 16, the intermediate risk group, which again, interesting, includes those patients with chromosome abnormalities of 5 and 7, which we see as people doing universally poor outside of the setting of transplantation, and adverse being a very complex cytogenetic karyotype, those patients doing very poorly. So how would you apply this scoring criteria? Well, this is a post-transplant specific cytogenetic classification, and its possible uses can be in prognosticating how patients will do after transplant. If somebody's at very high risk after transplant, maybe they'd be a candidate for some intervention to try and prevent relapse. Because as we'll talk about, once relapse has occurred, it's very difficult to treat. And the only success, in my view, that we'll obtain in reducing relapse is with trials of preemptive therapy. Next, it may actually have a bearing on your treatment choice. Again, we did show that ablative and non-ablative outcome is very similar, so in terms of regimen conditioning, it may not have an impact, but in the future it may help us define different choices for that. It can also help us in clinical trials. If we say everybody who goes to transplant, what's the outcome? We now realize that everybody who goes to transplant has a very different risk of how they do after transplant. So this helps in clinical trials, so you can then compare apples and apples and oranges and oranges. So let's move on to case number 2 for those of you who are still awake. And that brings us to a 64-year-old gentleman with AML whose cytogenetics demonstrate the 821. So this is building on what we just talked about in terms of age being an issue and cytogenetics with the 821, which, as we talked about a moment ago, characterizes a favorable prognosis. Does this patient get consolidation chemotherapy, transplantation, and if they do go for transplantation, ablative or a reduced intensity approach? Well, older patients, as mentioned, really are a different group of individuals, have a different biology than younger individuals. And if we look here by age, and we see patients less than age 60, their complete remission rates was 7 and 3. Those less than age 60, 70% versus 45%, already a very dramatic difference. Early mortality, 10% versus greater than 25%, and this is using traditional induction chemotherapy. Now, as many know, people have moved on to more gentler forms such as decitabine or 5-azacitidine. Disease-free survival, humbling, 45%, and we can see a very dismal, less than 20%, and that 20% is probably optimistic. And long-term survival, 10% in those patients over age 60. So why do patients who are older experience worse outcomes? Well, it's probably, again, some of it is due to fitness, decreased host tolerance of intensive chemotherapy. Many patients probably have a prior antecedent hematologic disorder manifested in their stem cell reserve, presence of comorbid diseases, and decreased chemotherapy clearance. An increased resistance to therapy is also noticed, and we can see a profile of a favorable and unfavorable compared to both younger patients receiving chemotherapy. And there's also well known a high expression of drug resistance genes in these populations, and as mentioned before, a high incidence of MDS prior to AML, which defines poor outcome. So if we look at the comparison of reduced intensity transplant to chemotherapy in CR1, let's look at patients age 60 to 70. Sharif Farag, through the Alliance, formerly the CLGB, in combination with the Transplant Registry, went and compared the outcome of patients who were 60 to 70 with AML who underwent transplant compared to those patients who got chemotherapy. And they chose people who were in CR1 for at least 4 months to help get rid of the bias that might be there. And what they found was that allogeneic transplantation was associated with a significantly lower risk of relapse. It was associated, unfortunately, with a higher non-relapse mortality, which is not surprising. However, longer leukemia-free survival, and importantly, overall survival was significantly longer in these patients. And Steve Devine updated the work from the Alliance group in combination with the CTN of looking at the role of reduced intensity transplantation in older individuals, again confirming this data that this provides a very reasonable option for older individuals. And here is again a slide from the paper by Farag showing the outcome for patients who underwent hematopoietic stem cell transplant versus those with chemotherapy in terms of non-relapse death. But importantly, here the issue is the risk of relapse. We can see almost universal in the chemotherapy arm compared to the group that was doing well after a hematopoietic stem cell transplant. Although plenty of room for improvement, there is no doubt about it. So when we think about the potential advantages of a reduced intensity transplant compared with an ablative transplant, as we approach any individual, how do we weigh which of these two strategies we should use? Well, the potential advantages to a reduced intensity transplant include less treatment-related complications, as Dr. Perales just presented. You can avoid many of the acute toxicities related to chemotherapy. Comorbid diseases are certainly less of a barrier to transplantation, and as he mentioned as well, patients with low ejection fractions, compromised pulmonary status can proceed to transplant where in prior days they were not eligible. Less graft versus host disease was hypothesized to be associated with reduced intensity transplant. Has really not borne out, because certainly everyone in this room sees lots of chronic graft versus host disease after these types of transplants. But there is data to suggest that it does cost less and it is associated with an improved quality of life. What are the potential disadvantages? Well, what's the increased risk of relapse by giving lower doses of chemotherapy or chemotherapy and radiation? So what are the factors to consider when looking at a patient to choose between a reduced intensity or an ablative transplant? Well, I think of the host issues. What's the risk of treatment-related complications? What are the comorbid medical conditions that would make proceeding with an ablative transplant too risky? Is it a second transplant where we know there's a prohibitively high risk of complications and advanced age? But importantly, what's the disease-specific issue? What is the susceptibility of the underlying disease for the patient proceeding to transplantation? If we talk about CLL or low-grade lymphoma, well, there's a disease that's very reasonable to proceed with a reduced intensity approach because the curative aspect is probably the immune system. AML, MDS, not so much, kind of right in the middle. Chemotherapy is probably good, but graft versus malignancy is also there. So how do you weigh those two things? So you really have to think about what the role of dose intensity is in the cure of the disease. Well, we tried to address this a number of years ago at our institution, looking at people over age 50, and we looked at people over age 50 and compared patients getting a non-ablative transplant with an ablative transplant. We looked at overall survival, GVH, treatment-related mortality, and relapse. And these were the slides that were generated showing that not reaching a level of statistical significance, the outcome in this non-randomized population was about the same. So what does this tell me? It tells me that you're not doing somebody a disadvantage by proceeding with a reduced intensity transplant over age 50. How about progression-free survival? Again, curves essentially superimposable for those two areas as well. Cumulative incidence of treatment-related mortality we can see is higher with the transplant, and then the cumulative incidence of relapse, most importantly, was higher with respect to the non-ablative transplant compared to the ablative transplant. And that's been reproduced in many studies over and over again. So what's the conclusion that we reached was that despite adverse prognostic factors in patients over the age of 50, and this was all comers, treatment-related mortality was reduced after the non-ablative transplant. However, the risk of relapse of the disease was higher after a non-ablative transplant. When we look specifically in patients with AML and MDS, we actually saw that there was a potential progression-free survival advantage in those patients who received an ablative approach. So that's our angle for those individuals. Just very briefly, if we talk about graft versus host disease prophylaxis, my colleague Dr. Seufer looked at a large number of people undergoing mini transplants and looked at the issue of who the donors were and, most importantly, what the role of T-cell depletion was in outcome. And if we look at the results, he looked at patients who received ATG and Campath and compared them to non-T-cell depleted regimens. And we can see, not surprisingly, the rates of acute graft versus host disease were lower in Campath compared with ATG and T-cell replete regimens. Chronic graft versus host disease was lower in both of the regimens to reduce T-cell burden. Relapse was more frequent in the Campath and ATG arms compared to the T-cell replete form. And disease-free survival was lower in those groups as well. So what does that tell us? Well, it tells us that while ATG and Campath may help us reduce the risk of chronic graft versus host disease, it increases the risk of relapse and compromises outcome for transplant. And we can see, most importantly in this slide right here, the risk of relapse was highest in those groups receiving the T-cell depleted therapy. So when we look at how we choose a donor, this was another analysis we did at our own institution where we looked as to whether one should choose a related or an unrelated donor. This work was done by Vincent Ho. We looked at patients who either had myeloid malignancies or lymphoid malignancies, and we asked whether there was a benefit to using an unrelated donor compared to using a match-related donor. And to my surprise, I had originally, when we thought of this idea, thought that we would find the difference in the lymphoid malignancies, but indeed we didn't. We only found it in the myeloid malignancies. So one of the debates as we mature our understanding of who we should choose as a donor is maybe this unrelated donor gives us a greater allogeneic effect, and that's where the benefit is seen. So how do we prevent relapse? So just in the last couple slides, we'll talk about ways to do that. One is by intensifying the dose intensity of the chemotherapy around the time of transplant, but we know that has diminishing returns. Novel agents to include in the conditioning regimen, such as radioimmunoconjugates, have been used. But what I'd like to focus on just for a few minutes are the role of prophylactic DLI as well as the role of vaccines. So donor lymphocyte infusion is well known to those in the audience, where the cells are collected from the original donor and infused. Response varies by disease type, and the way I approach this is by looking at what the relative intensity of graft versus malignancy effect. And this slide is out of date because while it's still true that the most significant graft versus malignancy effect is seen as CML, CLL, and low-grade lymphoma, it's now been recognized that ALL actually has an appreciable GVL rate as well. So again, where people are on that spectrum, these patients respond very well to DLI. These people have an intermediate response to DLI. And what are the indications for DLI after transplant? Presence of minimal residual disease, frank relapse, and some institutions use mixed chimerism as a surrogate marker. How about the role of prophylactic DLI in patients with high-risk AML? Again, in my view, the only strategies to help prevent relapse will need to be preemptive strategy. Once relapse has occurred, outcome is uniformly dismal in most cases. If we look at those patients where DLI was administered after 120 days to patients off immune suppression, the group in Germany used escalating doses of DLI in a group of patients, and they found that patients with similar risk profiles, those who received DLI versus those who didn't, there was an improvement in survival, suggesting that a prophylactic strategy based on certain appropriate triggers for the administration of DLI is a reasonable preemptive strategy to try and prevent relapse. So lastly, I'd like to just close with a strategy that we've used at our institution, which is vaccination after the transplant to inspire the donor's immune system to try and make the disease go away. And this is work that was started by Glenn Dranoff over a decade ago and has now been carried forward by Vincent Ho and Rob Soifer in the group. And what they do here is try and use GM-CSF as a way to augment donor immunity. And what they've done is they've taken the GM-CSF gene and transduced it into leukemia cells. They then irradiate those leukemia cells to prevent proliferation, and then the GM-CSF in these transduced cells is detectable in patients. And it's been shown to have biologic activity in melanoma, lung cancer, and MDS and AML. So the strategy is to collect the cells, and this is a treatment program here. The patient has evidence of disease. We perform a bone marrow. We collect the leukemia cells, and the leukemia cells are transduced with this GM-CSF vector. The patients then underwent chemotherapy, which at our institution is fludarabine and busulfan, received the stem cells, received traditional tacrolimus and methotrexate, and then importantly, patients receive vaccination while still on immune suppressive medication. And they receive what's been termed the GVAX on these days, and then subsequently their GVH prophylaxis is tapered. And what we can see in a small study that's been previously reported is those patients who were able to receive all their vaccinations did extraordinarily well compared to those patients who were not able to receive the vaccinations. And what that suggests to us is that we may be able to induce some anti-tumor immunity using this approach. This is some of the responses we've seen to the GVAX, which is given both sub-Q and intradermally. You'll often see erythema around the site, and when a biopsy is performed, you see a marked infiltration of lymphocytes, particularly CD8-positive lymphocytes. And what are the targets? Well, GVAX elicits a coordinated both humoral and cellular response. We've done a lot of work in Dr. Ritz's lab and Dr. Dranoff's labs looking at what the potential targets of that may be, and some of these are listed here. And hopefully some of these targets that we identify will be future targets that we'll be able to more specifically target the GVAX for. So that, in conclusion, a lot of advances in AML. Now using genetic markers, we're able to better define the role of transplantation for patients with normal cytogenetic AML. For those older individuals, transplantation is a very reasonable option. And really the approaches that we now need to focus on are how to prevent relapse, particularly through preemptive approaches. And what I'd like to do is just acknowledge my colleagues who I work with, and most importantly, I'd like to acknowledge the physician assistants that are in our group, led by Deb Yolen. It's a group that's grown over the past decade, and they're a spectacular group of individuals who deliver outstanding care to our patients and families. And we have an equally wonderful group of nurse practitioners in our group who provide, again, wonderful care to our families and with patients, and without them, the outcomes would not be possible. So again, thank you very much for asking me to speak.